webinar group under the leadership of Dr. Vijaya ma'am. And today we have an excellent speaker with us, Dr. Jayesh Amin sir, who is going to talk on the immunology in RPL and recurrent implantation failure. So as we go into the webinar, we have our 6 great chairpersons who are going to be involved in the webinar too. And they are all people who are going to be a part of the elections, upcoming elections. And we have our own Dr. Vijaya ma'am. So Vijaya ma'am, to introduce her, she is a candidate now for the chairperson for Foxy Medical Education Committee 2025. Ma'am is the president of Foxy from 2024 to 25, former director of IOG, former director of the Social Obstetrics and Gynecology in MMC. And she has been awarded the Best Doctor Award during the COVID pandemic for her management at that particular point. She had been the member of the Foxy and Oxy Medical Education Committee, and she has had a very vast experience, about 30 years of teaching experience for both undergraduates and postgrads. She's been the faculty for UG and PG revision courses here in Tamil Nadu, and most of them would be her students here. And she is a state-level master trainer, a state-level master trainer of cervical cancer screening program and colposcopy, and also in the emergency obstetrics and neonatal care. She's been a national master trainer in safe delivery practices, and she has also played a key role in Lakshya certification for the IOG, KGHISO, and ESI College and MCHKK Nagar. Now, she has also done the Aksharam webinar series from April 2024 to March 2025. And now presently, she is running the OBGYN Pulse webinar series. So welcoming the convener of Aksharam webinar series, the present convener of OBGYN Pulse webinar series, a person with more than 3 decades of teaching experience. Vijaya ma'am, can I request you to take over and introduce the chairpersons and the speaker for the webinar today, please?
Thank you, Madhu, for such a wonderful introduction. Can I have Dr. Madhu's slide, please? Dr. Madhu? Okay. Yeah. Madhu is a gynecologist and for move the slide little up. No, the last line it cannot be seen for Madhu. Dr. Madhu is a gynecologist and she is director, clinical director and senior fertility physician in Nova IVF Infertility at Chennai. And I know her for ages and she was my student and she's a very good orator and very good debate person. And she is no way connected to Foxy, but yet for me, she has been there for all my webinars and she is a coordinating person for all the speakers and the chairpersons. Thank you so much, Madhu, for your involvement and with no repercussion. Thank you so much. And she has the awards of Oxy, RCOG and AACOG. Yuva Izar Award, Youth Icon Award and Best Paper, Cox 2024. She has publications in BJOG and UCP and she has a special interest which I like so much, biological hair for poor ovarian and sperm reserve patients and also in onco-fertility. Thank you, Madhu, and welcome you for this webinar.
Thank you, ma'am.
Can I have the chairperson slide, please? Yeah, okay. Let's go to the...
Shall we start with the prayer and then introduce the chairpersons, ma'am?
Okay.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Let's start with the lighting of the Kuttuvalakku.
Sagiti? Yeah. Let me have the pleasure of introducing our chairpersons. The first chairperson is Dr. Bhagyashree Sudhi. She is a consultant obstetrician and a fertility specialist, laparoscopic surgeon at JAIU's IIM SRC Badnapur Life Care Hospital. And she's a honorary secretary of Aurangabad OG Society. And she's a honorary treasurer of AOGS 2019 to 24, Managing Committee Member of AOGS 2018-19, Honorary Treasurer of OBGYN Sonocon 2019, contributed a chapter on internal iliac artery ligation in Das Gupta's recent advances, presented paper at the state level and national level conferences. Welcome, Dr. Bhagyashree, ma'am. Next.
Thank you, ma'am.
Yeah, you have come. I didn't see you. Yeah, hi, good evening. Yeah, just rename yourself. Rename yourself, Bhagyashree. Your Sagiti, rename Bhagyashree, ma'am.
Hello.
Yeah.
Hi, Bhagyashree. Namaste. Rekha
Yes,
Rajendra Kumar
namaste,
here.
ma'am.
Bangalore.
Yeah.
Namaste.
Ma'am.
Hi, namaste.
Yes,
I have the
namaste.
pleasure of introducing Dr. Venkata Ramana. He is MBBS in Kurnool Medical College and MD in Mangalore. He has a special training in laparoscopic surgery, 23 years of service in Kurnool Medical College as assistant professor, associate professor, and HOD retired like me, sir. Presently working as professor of OBG as Vishwa Bharati Medical College, Kurnool. Done more than 5,000 DPL surgeries and advanced lab surgeon. And he has a KMC alumni and ex-president and IMA vice president, member of the Safe Motherhood Committee Foxy 24-26, Dira Awardee, Best Doctor Awardee, President Kurnool Obstetric Society, and AP State Government DPL trainer. Sir, I'm very, very privileged to have you for my webinar, sir. Welcome, sir. Venkat, sir.
Sir, muted. Venkatramana, sir.
You have muted.
Sir, you are muted.
Hello, sir.
Unmute. Unmute, sir.
Thank you, madam. Thank you for introduction.
Thank you, sir. Can I introduce Dr. Nirmala Devi?
Sir,
Yeah.
Venkatramana, sir, namaskara. Dr. Rekha
Namaste,
Rajendra
madam.
Kumar.
Rekha Rajendra Kumar, madam. Namaste, madam.
Sir,
Radha,
Namaskaram.
sir. Yeah. Nirmala Devi is DGO, FART, FMAS and DMAS and LLB also. She Kanaka Mahalakshmi Hospital, Yelluru, Andhra Pradesh. She's a present president of Yelluru Obstetric Gynec Society and she's an organizing chairperson of APCOG 2024 and president APCOG 2025. Lots of award, Vishita Seva, Puraskar Award 2007 by X-Ray Organization Vijaya, Excellence Award 2007 by Healthcare International Hyderabad, Glory of India awardee by FIIS New Delhi 2008, Champion Presidency awardee Rotary Districts 2020 for the Rotary year of 2014 to 2015, major donor to the Rotary International donated US $10,000. Can you move up, Sagiti, to the
Wow.
slide?
Wonderful.
Sagiti, move up the slide, please. No, that slide is not visible properly.
Yes.
Madam, slide.
Can you see now, ma'am?
Yeah, just move up a little bit. Yes. Little move up, no? Because maybe my screen there is some problem. Not seen, Sagiti. Let it be like that. Yeah. And she's a major donor to Rotary International, donated more than $10,000 to Rotary International, Assistant Governor 2018-19, District Chairman Maternal Child Health, and District Chair for NCD district chair for polio pulse, and she has special interest in social service, music, singing, classical and light. Oh, wow. Welcome, ma'am. Nirmala ma'am, welcome. Next. Yeah. This is my own dear friend, Mrs. Rekha, and she is Dr. Rekha Rajendra Kumar. She is, you can see, first rank in MD, 7th rank in MBBS, DNB, FICOG, and FKCOG, and FIC MCH, Fellow Reproductive Medicine of ICOG, All India Topper, and Medical Director, Miracle IVF Hospital and Chandana Hospital, Bangalore. And she is practicing for the past 34 years, President, Bangalore Society 24-25, and late Professor Kutti Lifetime Achievement Award by Foxy 2024, Organizing Chairperson of FemPower, Foxy National Conference 2024, Organizing Chairperson of MDIP Conference 2024, Bangalore, invited faculty in more than 1,000 state, national and international conferences, EC member of Karnataka branch of Indian Society of Assisted Reproduction 23-25, EC member Kasoga 24-25, South Zone Coordinator for Medical Disorders 24-25, South Zone Coordinator Foxy Infertility Committee 21-23, founder EC member of Karnataka branch of Indian IFS 2019-23, life member of Prestigious Society, peer reviewer of Jogi, chairperson of Isoga Infertility and ART Committee 2020, and Ethical Medical Education, Medical Legal Committee 23-25, past member of Sexual Medical Committee, Endocrine, Food and Drug Committee, joint organizing secretary of OBGYN 2021, Foxy Figo, ESOFAG and BSCOG international conferences, 21 hour 26 felicitation, including 1 international, 3 state and 2 Foxy, ex-PG teacher of Ramaya Medical College and Bangalore Baptist Hospital, and 29 original articles, case report and poster presentation in Asia Europe Conference 2021, more than radio television talks, 100 camps and 40 newspaper articles. All are women's health. Who can be a better person for the Medical Disorders Committee? And my dear friend Rekha is contesting for Medical Disorders and Pregnancy Committee for this election year. Please, whoever has logged in, please vote for her. Can I have the next slide, please?
Thank you so much, Dr. Vijaya, for giving so much of opportunity to me, as well as being so kind and good to me in reading such an elaborate introduction on me. Thank you again.
Dr. Umayal is another one of my dear friend from Chennai, Managing Director, Kumaran Specialty Hospital, Tambram, and the President of Kanchipuram Obstetric Gynec Society, and she's an Organizing Secretary of South Zone VP Conference 2024, past President of IMA Tambram, Chairperson of Women's Wing IMA, Tamil Nadu State Branch 24-25, and State Council and Central Council member of IMA. Umayal is yet to join, I think we'll call her. Yeah. And she is contesting for violence against doctors, very, very important. She is contesting for violence against doctors, and please vote for her. Next slide. Yeah, Radha Lakshmi, and my dear friend, she's a professor of obstetrics gynecology in SRMC, Nandyal, Secretary of Kurnool Obstetric Gynec Society, Zonal Coordinator of NTRUHS AP, in charge of Mission Pink Health, IMA Kurnool, 30 years of teaching experience, UG, PG examiner and DNB examiner, organizing secretary of E3 Confoxy and national conference also, conducted full day CMEs with credit hours, chairperson and speaker in various national, state level conferences, along with several papers and posters, and conducted Foxy Cultural Festival in Kurnool. She is contesting for Medical
Clinical
Research Committee Foxy, and please vote for that. The voting date is from 10th to 15th to 25th. Correct, Rekha?
So thank you, thank you,
ma'am.
Vijaya.
Right. Yeah.
Yeah.
Thank you, Vijaya,
Yeah.
for introducing me, and I request all of you to vote for me. So, and Jayesh, sir, I know more about you. I have seen you in many conferences, at national conferences, and you achieved a lot at a very younger age. And congratulations to you, sir. I want to meet you personally in one more conference future.
Yeah, can I ask
Can I now request
Dr. Venkataramana sir to introduce our
Madam.
speaker of today?
Okay, ma'am.
Requesting all the presidents and secretaries who have logged in to vote for me, Medical Disorders in Pregnancy, Dr. Rekha Rajendra Kumar. This is in person. I'm requesting once again. Thank you so much, sir.
Good evening, everybody. It is my great pleasure to introduce Dr. J.S. Amni. He is the clinical director of Nova Wings IVF Group, National Advisor, Indian Fertility Society, President Association of Reproductive Genetics and Immunology, Organizing Chairperson IPS 2024 Ahmedabad, past Traditional Joint Secretary, Indian Fertility Society, past Convener, Fertility Preservation Society, and he had achieved many more than 20 years of experience, more than 30,000 IVF pregnancies, and he's more academicians and nice persons. Welcome, sir. Welcome for this webinar, sir. Thank you.
Thank you for nice introductions, Doctor. All are something I'm very excited to take this immunology because it's very difficult. So I'm just sharing my slide.
Yeah.
I think so. My slide is visible.
Yes, sir. Make it full screen, sir. It's
Yeah,
visible.
yeah, I will. Just setting it. No. Thank you.
A very good topic, Dr. Vijaya. Thank you.
All Madhu, credit goes to Madhu. Anything in IVF, she is the person who will select the topic, select the speaker.
So I think so. Good evening to all seniors, and best of luck, and my always best wishes that you will win whatever the contestant you are participating. And the topic is navigating immunology in RIF and RPL. First of all, we need to understand that where we are, specifically when we are talk about the implantation failure, and when we talk about the recurrent, that means again and again failure. So we are still having no definition that what you mean by recurrent implantation failure. The traditional definition is focusing on number of embryos, and we need to also consider the maternal age, because is against maternal age, maybe number of embryos may be higher. And that is why what we understand that one size is not going to fit for all, that a fixed number of embryos transferred will cannot be considered as an implantation failure. And to answer it, I think so the ASHRAE recommendation, good practice for recurrent implantation failure, and they make a model, and by that model, to make the model very easier, they transfer single embryo transfers, and per embryo transfers, they find out the implantation rate. And after that, they also decide a threshold that according to that threshold, whenever the number of embryo transfers, if they reach more than 60% and still there is no pregnancy, there is implantation failure, then there will be a something which is called, we need to add on and we need to do something more and find out why there is implantation failure. And about that, they formed the table which shows that whenever the untested embryo which was transferred in less than 35, you need to intervene if there is a 3 embryo transfers. And when the age is 35 to 39, it will be a 4 embryo transfers. But when you go on the euploid embryo transfers, the number of embryos are consistent, that whenever there is a 2 euploid embryo transfers, and if there is no pregnancy, will be considered as a recurrent implantation failure. Definitions will be there. So the algorithm which was for showing that if you are transferring the embryo, let me just give you example, the female who is she having a less than 35 years of the age, and if you have a transfer of 1 embryo or 2 embryo, that means you are still not reaching, your still cumulative chance of implantation pregnancy. When you transfer a 2 non-tested embryo, then it is less than 60%. So what you can do in the next, you have to proceed for another 1 more embryo transfers. But when I say that, when the patient is having a more than 35 years, and if you already transferred a 2 genetically tested embryo, and if there is no pregnancy, means according to that chart, you reach more than 60% cumulative chance of pregnancy, then yes, you need to define as, and you can follow up as a RIF patients, and you can investigate and you can intervene in this group of the patients. This is again 1 more retrospective data of Lugano workshops, and what they say is that, and that is what I am following in my clinical practice, when the age is less than 35, whenever the 4 number of the embryo. So I do explain my patient that either as I shifted my practice to single embryo transfer since last 2.5 years, even whether non-tested or tested, by a proper counseling, we can transfer only single embryo. And when we transfer single embryo, if a 3 embryo which was transferred in less than 35, we can consider, or maybe a 4 embryo transfers, we can consider that yes, now we need to intervene and we need to define these patients as a recurrent implantation failure. And when we are defining recurrent implantation failure, we know that the cause might be embryo, it may be in the endometrium, or maybe what we can say, it's maybe a crosstalk between the embryo and endometrium, which may be different. So here today, much more we are discussing regarding the crosstalk. But before that discussions, let us see, this is the retrospective data where 4,429 patients where embryo transfers was done. And after single PGT normal embryo transfer, the clinical pregnancy rate is around 69.9% and live birth rate is around 64.8%. So what question arises in your mind? What about that even after in a good prognosis patients, when the uterus is normal and there is no chronic endometritis, the endometrium is triple line, what about why 40% failure when you transfer single genetically normal embryo transfers? And when we transfer after the dropout patient, those who are 30%, we transfer another 700 patients, then the clinical pregnancy rate of single embryo in the next group of the patients is around 60%, and the live birth is around 54.4%. And then the remaining another 100 patients when we transfer, then again the clinical pregnancy rate 60.3% and the live birth rate is 54.1%. So after three successive PGT normal embryo transfers, the cumulative live birth at the end of the day, when we add, it is around 92% and clinical pregnancy rate is 95%. And if you look around that every PGT normal embryo transfers, the first transfer, it shows around miscarriage rate is around 7.8%, 8.2% and 12%. Average 10% pregnancy loss will be there. So what is your question? Why there is a miscarriage even after genetically tested normal embryo? And when we have a patient, those group of patients, those who are having a recurrent pregnancy loss, more than 2 or more than 3 pregnancy loss, what we consider that we first check the patient according to ASRM guidelines, all the screen, the weight, extremities and the habits and cavity check by hysteroscopy and 3D sonography. We'll screen the antiphospholipid antibody syndrome. We can screen the TSH, anti-TPO, prolactin, and also we can check for the diabetes basically by the HbA1c. Even after all the screening and the supplementation, even if there is a recurrent miscarriage, more than 3 miscarriage, then the last, the guideline, we say that you can advise PGTA in the advanced maternal age and counsel the patient. It will only reduce the spontaneous chance of the pregnancy loss, but it will not going to reduce the recurrent chance of the miscarriage will be there. So to address now, the question arises that when there is a recurrent implantation failure and recurrent pregnancy loss, when we should investigate for the immunology, and why should we consider, which are the conditions when we should investigate for immunology, is all about that when the patient, those who are having a 4 to 5 single embryo transfers without genetic testing, if it fails in the younger group of the patient, a patient, those who are having a more than 4 miscarriage, consecutive miscarriage, the patient, those who are having a PGT tested 2 or 3 embryo transferred, and the patient, those who are having a PGT tested embryo transfer, but still they are having a consecutive miscarriage more than 2 or 3 times, how we can answer. And here I think so, we can investigate the immunology. Before to investigate, let's see what about the physiology of the implantation. This is the pyramid of implantations, and look at the preconceptional loss. Even the nature, when the embryo which was transferred by the nature, you can see that the human species, the 30%, they are genetically abnormal. But apart, when we test genetically normal, still there are preconceptional loss. which are the vanishing pregnancy, which might be considered is a rejection by a body. And we need to open this black box of the rejections. What is the reason of rejections? Why the embryo, which is genetically, naturally, or artificially tested genetically, why it is rejected? And why there is a continuous or recurrent miscarriage will be there? What is the reason? What is the reason behind the rejections? But when we want to investigate, again, we'll have something beyond when we investigate the ESHRE recommendation and guideline, which going to hinder our investigation. They said that it is not recommended, maybe regarding the HLA or maybe regarding the KIR or maybe more other immunological investigations. They still say it's not recommended. But what we can consider not recommended, that means it should be recommended in a precise, not for all, not routinely, but you can also do when the all measures are failed. And looking to that, what I want to say about the ESHRE guidelines, that ESHRE guidelines are an invaluable starting point, but they should be adopted, not adopted blindly. Fertility care in India requires a balanced approach. The global best practice combined with local realities, by prioritizing clinical judgment and investigating in local research, we can provide a better care and achieve. And better cares for our patients. Let's focus on creating India-specific solutions while building on the global expertise that ESHRE provides. So we need some India-specific guidelines for RIF and RPL. Look at the history. If we find out that why rejections, and if you consider the rejections, the Madawar before 70 years back, he says that pregnancy is an immunosuppression. That means that there is a profound immunosuppression and embryo will escape from this immunosuppression and get a 9-month pregnancy. But this is wrong. After 70 years, what we understand that when we investigate the endometrium behind the trophoblast, then we find out a lot of immunological cells. It may be a macrophage, it may be a T cell. And when in a model, when we remove this, all the immunological cells, it was found that there will be no implantations. That means there will be a definitely role of this all immunological cells. And what we found that in the pregnancy, that 70% are nature killer cells, 20% are macrophage, and 10% are the T cells will present during the implantations. So the theory which was told that pregnancy is immunosuppression, which was wrong, because it was easily found that when we are giving influenza vaccine, and mother should have response to that vaccines and forming the antibody. So pregnancy, it is a complex condition where the maternal immunity will always fight against the normal infections, and they also tolerate the baby and they push the baby for the 9-month pregnancy. So by that, we can come to know that pregnancy is immunotolerance. It's not immunosuppression. Now let us say how we can open this physiology of immunotolerance. Before that, I can say that the immunity, that means there are two types, innate and adaptive, that initially 4 hours, whenever any foreign body enters, the macrophage, dendritic cells, and the monocyte will attack with the phagocytosis, and they will, the other natural killer cells, the cytotoxicity, they will kill the foreign body. But when we are giving, they expose again and again, the antigen presenting cell like dendritic cells will go into the thymus and they will again initiate the humoral immunity. That means two immunity, cellular immunity and humoral. In cellular immunity, they have a 2 type of the cell T lymphocyte activation, the CD8 that is called cytotoxic, and CD4 plus that is called cytolytic. And also this T cell is also going to activate the B cell, and by that they form the antibodies. And they will store this memory. So whenever this foreign body will come again, this antibody will protect the paternal the antibody present will be protect that, make the organisms. So now let me consider that the foreign body entered, the innate immunity activation, natural killer cell response, acquired immunity activations, the killer cell modifications, regulatory cytolytic cell formations, antibody productions, and antibody persistence. That is what we understand by our immunity. Now, how we apply in our pregnancy. So pregnancy, when the lady who is she married and trying for pregnancy, they do have exposure of the semen or intercourse, and that sperm, when it enters again and again, the antigen load is smaller. They will go to the lymph node, and where that the dendritic cells, that antigen presenting cell, that will carry the sperm antigen to the adaptive immunity into the thymus, and where, because of the T cell activations, they form a paternal antibody. Not only paternal antibody, they again form the exposure of this, all the native T cells will lead to a formation of the T regulatory cell. And these T regulatory cells are cytolytic, and they are protecting the pregnancy. Now, during the healthy pregnancy, now what this is all about, the immunotolerance. So immunotolerance means there is a formation of paternal antibody. Immunotolerance means there is a formation of Treg cells. This Treg cells is not present only in the blood also, but they are highly accumulated in the implantation site when there is a desideralization. So in the desideralization, there are the high level of the Treg cells. So this is called immunotolerance will protect your pregnancy. So by that, what we understand that after the sperm entered with the intercourse, because of the T cell activations, there is a formation of the Treg cell. And also you can see the diagram, there is a paternal antibody formations. And this paternal antibody, if you can see, whenever the embryo will come, they will protect. First, the trophoblast will enter, and they will protect the embryo by this paternal antibody. So anyhow, now we understand, if there is a no immunotolerance, then there will be a less paternal antibody, and there will be a less Treg cell. So I can consider that intercourse will works like a vaccine, and paternal antibody will exist after intercourse, and Treg cell in the blood as well as in the decidua at the time of implantation, and that is called immunotolerance. And that immunotolerance is required for the acceptability of the pregnancy. But then it means what? Nature is doing a transplantation since so many decades, and we started a kidney transplantation after that, after the nature transplantations. And what exactly we believe it is, the embryo transplantation looks like a kidney transplantations, and the answer is no. Then why? It's all about that the embryo is a semi-allograft, the 50% of the cell which is coming from the mother. But nowadays, what I want to say, the whole theory is mimicking just like a embryo transplantation. It is just like a tumor which is transplanting in the body. It's a tumor. As tumor is slowly developed, pregnancy is also slowly developed. The antigen load is the initial time is lesser. So the body do have a time to get this antigen, and the antigen presenting cells will go into the thymus, and they produce a different immunotolerant cell like Treg and paternal antibody. So nowadays, what we can say, the theory which was that the embryo transplant is considered as a tumor transplant theory rather than a kidney transplant. How they differ? Because they are slowly, gradually growing. Pregnancy is always so slowly they are releasing their antigen, and that's why the nature do have a time to form a immunotolerance mechanism. So now we understand that fetus is a semi-allograft, and they will produce by that the slow, gradually low level of antigen and gradually antigen presentations, which lead to a more tolerance inductions compared to the kidney transplantations will be there. Now but then being a clinicians, when the patient, those who are having a 4 miscarriage, 4 implantation failure, how I can start my investigation? Should I investigate a blood? Should I investigate the endometrium? What I investigate? And today I will much more focus on the blood investigation, because endometrial investigation again is a big lecture. So I will say that I will go by the blood investigations, and if I investigate the people, those who are having a recurrent implantation failure and recurrent miscarriages, this is the immunology profile, the basic immunology profile that what we are performing. And by that, what exactly being a clinician, we need to focus. What exactly? I need to focus on Treg cell. If you here see the last line, FOXP3+, these are Treg cell, and the Treg and TS17. So this ratio should be higher. That means Treg cell should be higher. IL-10 should be higher rather than IF and gamma. CD4 cell should be higher. This is called, there is a proper immunotolerance, right? TNF alpha should be lower than TGF beta. So these are the things. This is the only 4 things that I can look and see that the baseline is normal or not. The thing is that in the recurrent pregnancy loss, we can considering these investigations and find out, and we will focus more on these 4 investigations. By that, we come to know that what is the immunology, basic immunology status. But in the past, should we focus, which was considered that natural killer cell titer? Is it peripheral natural killer cell? As we know that the peripheral natural killer cell can increase by any infection to the mother. And that is why later on there are a lot of meta-analysis which are saying that measurement of peripheral natural killer cell is not required. And as far as concerned the decidual natural killer cell, look at that, because whenever there is a pregnancy, it's an inflammatory conditions. And because of this inflammatory condition, the natural killer cells, which is increasing at the site of the implantations, at increase, so it is a pregnancy itself is a inflammatory conditions, and where there are more decidual natural killer cell will increase, they will increase up to first trimester, right? And then they will reduce when there is at term, when there is a delivery, there will be a parturitions will be there. So increasing decidual natural killer cell, which also not giving any informations in miscarriages, that whether it is not a marker to decide for a miscarriages. Saying that, these are the meta-analysis which say there is no significance of estimation of the peripheral blood natural killer cell. And that is why I would like to say that which investigation, that immunoprofile, basic immunoprofile, which are the 4 things that you need to measure that I already mentioned. So now, until now, what exactly we understand, when embryo enters in the maternal system, interaction with paternal antibodies, yes. And if there is a antibody is there, the trophoblast, which is basically genetically paternal in origin, so they will protect the trophoblast by antigen antibody reactions. And if there is investigations of implantation failure, that means there is no immunotolerance. That means there is no paternal antibody, right? And the role of natural killer cell implantation failure can be considered. Now, let me tell you that why there is no paternal antibody. Logically, it is something the patient, those who are having a vaginismus, they never exposed to the intercourse. Logically, if there is a close community marriage, logically, if there is a consanguineous marriage, and it may be an accidental compatibility will be there. So now how we can find out? So what we understand, whenever the embryo is entered, the antibody protections will be there. And this antibody protections is less. That means, look at this report. And this is the patient I want to say that the genetic compatibility. These are all the patients, all the alleles of HLA typing which was checked. And out of that, you can say that the 5 alleles out of 12 are matching. So if there is genetic compatibility is there, there is a chance that the paternal antibody is less. So now understand that the first test which we need to find out when there is a miscarriage and implantation failure, the find out clinically that immunotolerance is happened or not, we can do that a basic immunological blood test, and also we can do the HLA test where we can check the genetic alleles and the number of alleles compatible, how many number of alleles are compatible or not, right? So this is the first thing. Now, second thing, suppose you did that investigation, but it is still normal. There is no compatibility, but still patient is having a miscarriage and implantation failure. Then how can we open the other black box of the immunology? And it is all about that. Whenever the trophoblast, we know that trophoblast is having genetically more in paternal origin, and they try to go inside the decidua with the help of the HLA. HLA, that means human leukocytic antigen. Any cell, they do have an antigen on the surface. And there are two types of HLA antigen. It may be a class 1 and class 2. When we consider about the class 1 will have a A, B, and C, and class 1B is around G, E, F, and H. And class 2, which is around the P, D, Q, and DR. So these are the HLA antigen which is present on the cell. Now, important part is this extravillous trophoblast. So trophoblast, cytotrophoblast, syncytotrophoblast, and extravillous trophoblast, because this extravillous trophoblast will connect with the decidual nature killer cells. So extravillous trophoblast, a C is always present on the surface, and A and B is absent on the extravillous trophoblast. So we need to see the C majorly when we are having a problem of implantation failure and pregnancy loss. And even then later on with the pregnancy develop, G, E, and F also going to interact with the decidual nature killer cell. But the first interaction is HLA-C. It is first interact with the decidual nature killer cell. So what I want to say, if I consider HLA-C, then C is having a two type of antigen, which is inherited from the mother and father. It may be a C1 or it may be a C2. So this HLA-C is going to interact with the uterine nature killer cell, and now quantity doesn't matter. There are so many decidual nature killer cells, but it's all about that how this embryo will get a signal to the uterine nature killer cell, and that signal is whether activations or deactivations, right? So if this signal is balanced, we need a balanced signal, then the embryo will propagate and there will be no miscarriage and implantation failure. But if this signal is not balanced, unbalanced, then definitely there may be a miscarriage and implantation failure. And look at this diagram, that this trophoblast, when they have a HLA antigen, that may be a C1 or C2, they will activate and deactivate where the one protein ligand is present on the decidual nature killer cell, and which is called KIR, right? So the directly interaction will be not there. The antigen will interact with the KIR, and they have a receptor on the KIR, and that receptor, through that KIR, they will activate and deactivate the decidual nature killer cell. Now, let me say that how I can say how couple are going to be present in your clinical practice. So now there are two types of HLA, C1 and C2. Now say for example, the wife is carrying C1, C2 and husband is also carrying C1, C2. So there will be a 25%, those may be a homozygous C1, C1. And that means 25% may be a homozygous of C2, C2. And all other 50% embryo may be a C1, C2. Now, why I am telling that? Because there is a role of C1 and there is a role of C2 that I will tell you in the later on. But if you consider that, suppose a couple, those who are having the 3 C1, Here you can say mother is having C1C1, father is having C1C2. So 50% embryo will be C1C1, homozygous. And if there is a C1C2 and father is having a C2C2, 50% embryos are having a C2C2. So this homozygosity, how this homozygosity will going to make the pregnancy in a miscarriage and implantation failure? Because this C1 is having a high affinity on the keel on the activating receptor. So C1 is having a more affinity toward activation. So we can say like that, C1 is doing activation. It is going to be effect on the keel and they will activate the decisional natural killer cell. And let me tell you, if your couple is all C1, then definitely that only activation. There is no deactivations. And here, this type of couple may present in your clinic with repeated miscarriage because there is an absence of deactivation. It's all about the hyperactivation of the decisional natural killer cell. And that's why they might be lead to a repeated miscarriage. Let's say, what about the C2? C2 is a silencing. That means they are deactivating the natural killer cell. But suppose your couple is having all C2 accidental, then there is no doubt about they are lacking of the activation, and that these patients are present with recurrent implantation failure, and also they do have a more chemical pregnancy because there is no activation. So these patients are having a more chemical pregnancy will be there. So what I want to say here, I want to stop that whenever there is a homozygous HLA is there, if we have only C1, then yes, only activation. We have only C2, then we can have only deactivation, silencing. And when there is a more C1, the 50% is C1. So again, these patients may have a more chance of more number of embryos required to get one baby. And that's why in the journey of the pregnancy, they might experience of more pregnancy loss and tired, or may they get pregnancy after 4 or 5, whether nature or whether you artificially transfer, right? So here there will be what is the mechanism that we can understand. Now, this HLA where keel, so if the keel is a protein, it's a genotype. If there is a receptor on that keel, 80% are activating, then it is called BB. If there are 80% inhibitory genes, then it is called AA. So now if you have a C1, and if your key is BB, then their activation genes are higher. The deactivation genes are only 20%, right? So I don't want to say that C1, BBV, they are more activation, the more chance of pregnancy loss. And here I need to deactivate. So might be possible we can add IVIG and deactivate the decisional natural killer cells, and we can prevent the pregnancy. If the patient is having a multiple pregnancy loss will be there. I'm giving the example. This is a one couple which is C1, C2, and the husband is C1, C2, and the wife is C1, C1. If accidentally if the embryo is C1, C1, and if her keel is BB, that means activating, right? So anyhow, when C1 and BB will go, that will really create a more miscarriage will be there. But whenever the embryo will come C1, C2, right, then this is creating a baby. So there are so many times that first 2 miscarriage will be there, and third time they can get a baby. It is all because of this HLA key complex mismatch and polymorphism will be there, right? So that what we understand by this. So now we conclude here for this key complex that blastocyst adhesion. You can see extravillous trophoblast I show with the diagram. That extravillous trophoblast do have a C antigen because that is going to be interact with the key receptor. And this C are having a 2 type of antigen, C1 and C2. And this C1, C2 will act through a key. If key is AA, then inhibitory. If key is BB or AB, AB is 50% inhibitory and 50% activations, and BB is completely 80% activation. And that's why, look at this diagram, that embryo will activate the decidual natural killer cell, then this type of cytokines will release, and you deactivate and this type. So balancing both the cytokines will enter the embryo beyond 8 weeks of the pregnancy. Anything sharing is higher, paternal antibody absent, again they prevent the implantations and miscarriage. Or if there is a HLA-KIR complex is abnormal, there will be a higher chance of miscarriage will be there. So let me say something. This is my own ChatGPT diagram which I made on ChatGPT. Let me say that if embryo is a car, so I make a car, right? Now how car is run if engine is good? What do you mean by engine? Engine is genetically normal baby. That means engine. If your engine is good, how car is going to run? It's all required fuel. And that is what we want to say. The mitochondria is always cytoplasm, mitochondrial, and sometimes clinically we can correlate with the quality of the embryo. If the quality embryo is very good, or we can have some molecular science where we can in the future we can find out the potentiality of the embryo, that is called the fuel. But the third part is more important. Even after the fuel and the engine, why embryo will run? It's only because why car will run, because they need accelerator and brake, right? So I want to explain you in a very simple way that C1 antigen is accelerator, because with the help of the KIR activating antigen, they will activate the decidual natural killer cell and propagate inside the decidua. So C1 is accelerator, and C2 with the help of the KIR, they will deactivate. This is the brake. So both balance. Can you imagine if you are sitting in a car and if you don't have a brake, then there will be an accident, and which is called miscarriage, right? And the car which is having only brake and not having accelerator, the car will stop on the same way. So more implantation failure and more chemical pregnancy will be there, right? So this is how we can consider and we can understand, because it's a new science. So I want to simplify this science in a better way. And these are the publication which was way back 2016, 2017. And even though I think so, the EV presented a 2023 data, which I not incorporate inside this slide because it was made previously. Sorry for that. But I want to say that here they want to say that 25 patients, those who are having a more than 4 miscarriage, which was where the KIR and the HLA which was checked, and HLA of the embryo, and it was observed that when the HLA of the embryo is homozygous, the clinical pregnancy loss ratio and the implantation failure is higher. So homozygosity is often associated with a higher rate of miscarriage, but it's not only homozygous. So I will not explain. It's all about the homozygous. That means HLA as well as KIR complex is important. And to address that, one more retrospective data of 680 euploid embryo transfers which was done, and the DNA of maternal DNA which was stored, and by that they found that what will be the KIR. And then they also found the HLA of the embryo, and then retrospectively they found that where the miscarriage rate will be higher, which combination is miscarriage rate will be higher. And it was observed that the highest rate of the miscarriage rate will be when there is a homozygous like activation, C1, BB, and C2, AA. In my clinical experience, if I consider my all the experience, if I have a more miscarriage, more than 4, more than 6, I know that that patient definitely have a homozygous C1, and when I did the KIR, they will land up with the BB. And in my experience, when the worst condition, a combination of HLA KIR, which I found where I need a third party, which is called C2 and AA. because AA itself, AA is only 20% in our Indian population. Rest of the all 80% and 60% is always AB. We found our data when we do this scale, the genotype is 60% is AB, 20% is BB, and less than 20% is AA. I say that AA itself is carrying a higher risk because deactivation is worse compared to the activation. Activation is better, so BB is always better than the AA. So now you understand about all the thing. What we have to understand, signature of the embryo, that means HLA key complex, sharing, that means paternal antibody, and the only third part is now remaining, that after the 6 to 8 week of the pregnancy, the class 2 HLA antibody will interact with the embryo. That means there are autoantibodies. If the mother is having a more autoantibody for the paternal antigen or own antigen, then again pregnancy loss. And that we can investigate by the HLA-D. That means when we do HLA, that all things are mentioned, which was I am doing routinely by the Sarajan that is present in the Bangalore. They do have a research since 20 years, and I really commend that their research, whatever the research, is really very perfect. So let me tell you, embryo enters, paternal antibody, that means immunotolerance will be there. Confirmation of the antibody status is good. Okay, then it's okay. Now we need to go by the investigation implantation failure, where we need to do the signature of the HLA key. If we found HLA key is normal, then we have to select the always the autoantibodies inside the HLA-D system. So here, this is the case where you can say that how the more miscarriage, because here the patient is having a five alleles are matching will be there. So when there is a five alleles are more matching, it's a consanguineous marriage. Maybe they are husband and wife, but they are the biologically sister and brother because more matching will be there. And there are some studies there, more than 2 HLA matching, the chances of pregnancy loss and implantation failure will be higher. But I still doubt. I still don't believe in this paper. I still want to give my data. My data is saying that when more than 45%, yes, I agree. If there is more than 50%, actually this 5 or 6 alleles are matching, definitely these are the case where I always explain that you are a pakka case of I need to produce paternal antibody by giving LIT, but not husband LIT. So let me tell you now, you people are having if there is a sharing, then what I can do to produce antibody, more than 5, I will check the 12 alleles. And if there is more than 5 alleles are matching, 45% are matching, then husband LIT will not work properly. The 7 alleles are not matching. Maybe they produce some antibodies, but they already produce because of the intercourse. So we need more antibody for protections. And that is why we need to donor LIT. So I believe in donor LIT, and less than 5% of the cases, this donor LIT is required in recurrent pregnancy loss and recurrent implantation failure. And that is what I want to say, that don't do unnecessary LIT to all patients and then transferring the embryo, because you are randomly selecting a patient and giving all LIT will not going to be useful. It's all about to find out the compatibility. We know that when we do the test of the cross matching, then we found that there are so many pregnant female, when we cross match retrospectively, she is also showing no cross match. So this test is not that much of sensitive to giving a LIT. We believe that we can do that test also, but we will do HLA. By that, we can consider that what are the number of alleles are matching. And if there is a number of alleles are matching more than 45%, definitely we are interested in donor LIT in recurrent implantations, and recurrent pregnancy loss will be there. If 2 to 5 alleles are matching, then definitely I will wait for another one more accident. And if there is a recurrent miscarriage, then I can go by the LIT will be there. Let me go by this case series. This is the patient where husband is having 35 years, wife is 32 years, active marriage life is 10 years, semen report is normal, tubal patency is normal. The first IVF cycle, which was done in other unit, and they have a 5 embryo transfer in Melbourne. Single SET transfer was done. Because she is 32, no genetic testing was done. 5 blastocysts was transferred after, and they arrived at my clinic that we have an implantation failure. And as they don't have a time, they say, Dr. Jayesh, please investigate me. I did HLA Keir and I did IVF because they don't have a time. 10 years infertility, 1 IVF failure. They say that, okay, anyway, I required IVF. So we did IVF, second IVF cycle, and we have a 3 euploid embryo. But then if you see in the HLA, they have a 8 alleles are matching. The report is just missing, but 8 alleles matching, right? And 8 alleles matching. So I advised them to go for donor lymphocyte therapy. There are so many counseling which was done. We are doing low dose donor lymphocyte therapy 1 month before embryo transfers and every 21 days apart. Low dose, don't give high dose because there are chances of reaction. So we give always low dose lymphocyte therapy. So we gave them low dose lymphocyte. Then I counseled that your tubal patency is normal, semen report is normal. Why not you go? Because they don't have a time. I say you come after 6 months. There are chances that you might get a natural pregnancy. This is not one report. Wherever I give a donor lymphocyte therapy when the younger group of the patient, when alleles are matching, and they conceive naturally after 5 implantation failure. So this is a message to the obstetricians that there are so many unexplained infertility where we believe that IVF is the reason behind to treat them, where we are not exactly identified where immunology is the reason behind that infertility will be there. There are so many studies where there is a cross match recently published in 2022 and 2024, when there is a HLA matched husband semen, which is traveling in the follicular fluid. It was showed that the semen traveling transportation system is become weaker and their fertilizations is become weaker, right? So this is what the future will be there. We will find out, and we need to publish a multi-center trial that what will be if there are more HLA matching husband and wife will be there, then how we can treat and how we can investigate. This is the second patient. She is again, if you see that semen analysis normal, the tubal patency is normal, but she is having a 3 natural pregnancy loss at 6 to 8 weeks. One IUI was performed by the other clinic, which was negative. I never performed IUI specifically when there is a miscarriage. They investigated by the ASRM, all the algorithm, all other investigations are recurrent miscarriage will be normal. And when we did the HLA, the 5 HLA, which was matched. So again, 45% associated with the recurrent miscarriage. Previously, it is a recurrent implantation failure. This is a case which is called recurrent miscarriage will be there. We did donor lymphocyte therapy in this patient. Then because she is young, 29 years, after hysteroscopy, I counseled the patient that go for a natural pregnancy, but after 9 months, they arrived again that we didn't get pregnancy. Maybe they developed subfertility. So now this is another second good message when to act in recurrent pregnancy loss. If they have a consecutive pregnancy loss again and again, or if they develop subfertility, then and then we need to act. Beside that, we can say that to go for a natural pregnancy. And we did IVF, we did 3 euploid embryo transfers, first SET transfer which will be done, and she delivered a baby, girl will be there. So now another one message that I want to deliver. Anyhow, if you transfer double embryo, this is the one of the reason behind the pregnancy loss and implantation failure. First, convert your practice in single embryo transfers. There are so many patients, those who arrived at my clinic, because you just consider if there is a 4 C1, husband is C1 and all C1 is there, then you are transferring 1 embryo, then more activation even on the C1. But if you have a 2 embryo, then double activation will be there. Like that, if you are transferring the embryo and irrelevantly, if you are having a more C2 or more C1, then hyperactivation and silencing, the double embryo transfer will iatrogenic increase your implantation failure and pregnancy loss. So beside to move on immunology, why I shifted to immunology? Because I shifted my practice to only and only single embryo transfers. This is the prerequisite to find out what is the reason behind, because the double embryo transfer, it is the culprit, it is the cause behind of the implantation failure. This is my one oral poster which was accepted in the ASRM next year in 2025, and where we say that donor LIT, when the genetic compatibility is there, the output is higher compared to the husband LIT will be there. So now we know that signature, we know that the sharing, and now we need to understand about the systemic interaction. So there are so many cases where maybe that signature embryo is fine, the sharing is not there, but the mother herself is having auto HLA antibodies, right? Why? How we can investigate if they have auto HLA antibody, then they will kill their own embryo, own cell will be their auto antibodies. And that's why to find out that auto antibodies, I think so I will just go ahead with this is the case where because we are transferring now HLA key. People are having 4 pregnancy loss, and I know that if I want the HLA key complex embryo is important, so I will find out HLA embryo, and then I will find out that hierarchy. Beyond PGT, I will transfer that HLA embryo, which will give a best prognosis. So there will be no C1C1, there will be no C2C2, but it will be a C1C2 embryo, which will having a higher prognosis. So in this patient, it's a doctor patients where I did all these things and I transfer C1C2 embryo with Kiri's baby, and she conceived and she running a 7 month of pregnancy after 5 pregnancy loss will be there. So how? Now systemic interaction. In systemic interaction, we need to do the HLA, and our immunologists will advise whether the autoantibodies are there or not, right? If there is a high level of autoantibodies, there are so many HLA alleles, they will advise. And according to that, we will give the immunotherapy. So these are a lot of things which I don't want to go in detail, but these are the HLA, which are if associated that they do have a class 2 association in pregnancy complication, more miscarriage and intrauterine retardation of the growth, preeclampsia. So we need to find out all this HLA, systemic HLA. And after that, we will decide that which immunotherapy. So let me tell you that these are the all immunotherapy. I believe that please stop giving intralipid. There is no need of intralipid. Now, which are the immunotherapy that I can offer you? No intralipid, no SCQ. Which are the immunotherapy I offered according to the report? It is tacrolimus, it is prednisolone, it is low molecular weight heparin, and it is IVIG. These are the only immunotherapy that I do prefer. So there are so many people are doing intralipid and SCQ empirically. Please kindly stop it, because I do have a lot of experience. Now we believe that there is no need of SCQ and intralipid in your clinical practice. So donor LIT, I already say check the alleles. If there is a more 45% alleles will be there, then I will give the donor LIT. And if the alleles will suggest there is higher inflammation, pregnancy need inflammation. But if the alleles suggest there is a high level of inflammation, then you need to give tacrolimus, which will prevent your inflammation. Anti-inflammatory will be there. Higher inflammation, we need a balanced inflammations. So same drug, I think, so available in the market, which is called thymosin alpha. It is not cost effective. Tacrolimus will do a same action compared to the thymosin alpha. Still, we need more study, which is more potent. But till then, if the people are transferring 2 embryo and giving thymosin, there is no point. If the people are not doing genetic testing and double embryo transfers and giving thymosin alpha and saying that it is really effective in recurrent implantation failure, then there is no point. So we need a more multicentric data. I don't want to deny this drug. All drug is beautiful, but we need to give our multicentral data that tacrolimus is cost effective and thymosin alpha is not cost effective. But if it is more effective than tacrolimus, we might be using in the future in RIF. At present, I put a question mark of using tacrolimus empirically in recurrent implantation failure. And when I will give IVIG, see, one thing is more important. I never give IVIG without checking a HLA Kir complex. Because if my HLA Kir complex is abnormal, then even the autoantibodies is higher. But my embryo is not going to be implanted and giving IVIG is not worth. So I am always giving IVIG when I check HLA Kir complex. And then because the IVIG is not cost effective, it's almost around 75,000 to 1 lakh rupees is there. So I will reserve this drug at a last. At a last, I will reserve this drug. But I understand if there is an autoantibody is higher, and if you people are doing only single embryo transfer, might empirical use of IVIG sometimes will give you pregnancy. But should it give empirically? I will not give empirically. I will decide, I will segregate all the investigations, and then I will give IVIG. So in my clinical practice, I'm giving less than 5% to donor lymphocyte. I'm giving only the few patients where selected patients IVIG, and I'm giving tacrolimus according to where the patient is having a high dose of HLA alleles, which shows high dose of inflammation, high level of inflammation. And if husband HLA is having C07, then I will give low molecular weight heparin. If husband is not because C07 in kidney transplantation, it was observed that it will activate the pathways which is for platelet aggregations, and that's why the rejections will be there. So we observed when there is a homozygous C07 in that patient, even we gave 80 milligram of high dose of low molecular weight heparin, not a single spotting in that patient with the 6 mixed carriage previously is there. So it suggests that high C07 patients will always require high dose of the low molecular weight heparin. This is our own unpublished data, but because now we have a lot of 1,000 couples now, I think, so we reached of the HLA. And look at that, the recurrent pregnancy loss, which was observed more on the homozygous. C1 is having a more homozygosity than C2, and C2 is having a more chemical pregnancy. That is what our observations will be there. These are the certain alleles where we frequently check, and we will find out that which alleles. So now we are going to make an algorithm or maybe application that gynecologist or fertility specialist can enter their report, and by that we can find out that which alleles having the which more predisposing higher rate of miscarriage or implantation failure will be there. I know that the evidence which was published in ASRM of the immunotherapy is empirical. I believe that empirical use, no role of empirical use of all the randomly all immunotherapy. But in this meta-analysis, I think so there is no PGT, there is no properly investigation of the patient which was single embryo transfer. So I still believe that more data is required and more individualizations in the future is required, specifically in the recurrent pregnancy loss cases will be there. So what is my carry home message and conclusion? Abnormal signature of embryo will increase RIF and RPL require research. Sharing will require donor LIT. And systemic rejections can be treated by individualized immunotherapy. So I don't want to give a empirical immunotherapy, right? And the second thing, in our unpublished data, so we say that a C1 and BB is having a more chance of surrogacy because more miscarriage will be there, right? And C2 and AA, they require sometimes third-party donation. You can change. So the people, those who are saying that I am shifting donor egg, then there is no need of any immunology because you are shifting donor egg. That means you are changing all. So donor egg and embryo donations require no immunological investigation till when if donor egg embryo transfer is having a pregnancy loss, that means her systemic circulation is having a more autoantibodies. Then and then they require any investigation. Please don't put on LIT when you are doing a donor egg or embryo donation cycle. And again, the last important carry home message that please try to start, if your clinic is a tertiary center where your 70% case like me, when the patient do have a more pregnancy loss and implantation failure, try to start a single embryo transfer strategy that will prevent your unnecessary burden of RIF and RPL and also prevent a more investigation. Thank you so much.
Thank you, sir. Such a wonderful and it's a very, very tough topic, especially during our MBBS days. In microbiology, the immunology part is very tough to understand. And more so the HLA and C1C1, C2C2 and all these alleles matching. And I know this is not a common OBGYN's prescription of investigations, I think. Mostly these IVF people. My one question is, how much does this cost? All these allele matching, HLA typing.
So it is at present is not cost effective if you have a HLA, because there is no point to do only HLA. So HLA and Keel, if you are doing HLA and Keel both, I think so it is around 50,000 rupees cost is there, HLA and Keel. And that's why this all treatment is not cost effective. So we are always wait for single embryo transfers. And we will definitely explain the patient that, okay, this single embryo transfers will PGT single embryo transfer is a way forward first. But if you are having repeatedly with a single embryo transfer, definitely you are a case of immunology. Right.
So without testing, can we go to donor egg? And
yes, that's see, the thing is that yet now people are doing like that.
okay.
Definitely donor, if you change the donor egg, that means you are changing HLA. That means you are changing HLA key complex. So if the mother is C1C1, suppose father is C2C2 and mother is C2C2, and if you take the C1C1 donor, then again, your pregnancy rate will be higher. But when there is a pregnancy loss, don't transfer even donor egg double embryo. That means you are producing injustice to the science. Single embryo transfer is a way forward in implantation failure and pregnancy loss. There is
Can we ask the chairpersons to pass the comment? Dr. Bhagyashree, ma'am?
Yes, ma'am. Excellent talk, sir. Example of car was amazing. That is fuel, engine, accelerator, and brake for our knowledge.
Yeah.
Thank you very much, sir.
This is a very difficult topic, so I used to make it more simple. And if you don't make it simple, I think so people can't understand. It's a very difficult topic.
Yes.
So if you can hear for 3-4 times, then you can easily. But now this is something very so beautiful that the car and engine and fuel and accelerator and brake.
Yes.
This is what embryo will play a game in immunology science.
Dr. Venkatramana, sir, your comments?
So very nice presentation, sir. Format is a Greek and Latin. Openly, I can tell that because the subject is very tough to teach and to also. Thank you.
I think the message is very clear that there are a lot of unnecessary LIT which was done today should be stopped. There should be an ethical practice like single embryo transfers. The case selection should be always like that. If there is a recurrent history is there, this is what the message will be there. It's a very beautiful science, but if you are using it in a different way, I think so that will create a lot of mesh in the clinical practice.
Dr. Rekha?
Yeah, Dr. Jayesh, very good talk, very intricate topic, and you tried to make it much simpler so that everybody understands. I just wanted to make it very clear or ask you that you said there are 4 things like intralipids and HCQ you are not happy with. So can you just tell me which are the you don't use it properly, like
No. I want to say that intralipid is basically immunosuppressions. I think so.
Yeah, that's what.
If you give IVIG and if you give intralipids, so it's too much suppressions, right? I think so. Only IVIG suffice, and they have a better actions, better potent action than the intralipid, and that is what I want to say. But when in an obstetric practice, when you people are having a pregnancy, suppose so the other people, those who are obstetrician here, not doing IVF, and they have a natural pregnancy, for them, intralipid is cost effective and might in certain group of the patient, when you give empirically, that autoantibodies is going to be suppressed and they might have a pregnancy, right? But in my conditions, I don't want to give anything empirically. I say I can go ahead with the HLA typing, and if the only autoantibodies is there, see, there are so many conditions where gynecologists can treat. That if there is only autoantibodies, rest of the all conditions, maybe some good embryo will come and will implant. Then these are the conditions in clinical practice. We had seen something after 3 pregnancy loss, there is a 4 will be a pregnancy, which is because that HLA key complex is of the favorable complex. And if there is autoantibodies in that condition, you can give that whatever IVIG. I still don't use intralipid. I believe IVIG is more potent. But then I will never use, these are all treatment empirically in any patients, because I definitely find out what is the reason. And even though sometimes if sometimes what I want to do, that I will first transfer HLA queen complex and PGT. And even though she failed, then second time I will do IVIG. That is what I am doing clinical practice, because still data is not that much of, even I don't have that much of huge data where I can push my patients to take this type of treatment.
Dr. Radha Lakshmi, would you like to comment?
Just 1 minute. 1 minute. What are the 4 things you said you are in favor of? Tacrolimus,
I am in favor of tacrolimus. I am in favor of low molecular weight heparin. I am in favor of IVIG, and I am in favor of prednisolone.
Prednisone, not aspirin.
Only and aspirin is always there, because I am saying low molecular weight heparin. That means ecosprin is there. Aspirin is there. Considering both are same molecule, so I am considering that is a one molecule. Prednisolone always a very short dose. That means it's only needed peri-implantation. So 7 days before implantations, and after 5 days of the implantation, then you will stop it. So there is no point to start it in a very high dose, and then it will really people do have some, those who are diabetic, maybe this overuse of the steroid will not going to be work. And certain time when you yes.
Sir, one question, sir.
Mine is more of IVF. Mine is more of IVF practice, and I give prednisolone for 10 days post embryo transfer.
So it's a peri-implantation is always better. 7 days before and 5 days after implantation. So it's around 10 to 12 days surrounding implantations will always help you. But then again, when you give a high dose of prednisolone, they will always going to be a immunosuppression. So I want to say that activation is always better than. Hello.
Ideal dose of prednisolone?
See, it's all depending upon the what is the how much suppression, but we never give. I will give always in my practice 10 milligram. 10 milligram only. When it is really indicated, when you know that there are autoantibodies. If there is no, then I will never give, because prednisolone again in my clinical practice, in this much of all clinical miscarriage and everywhere, I am giving a very few. I will find out the exact number of the percentage, but I will tell you something about is a very less number of the percentage where I able to give prednisolone as a treatment. So it's all about that. You do HLA, then you will find out whom to give prednisolone, whom to give IVIG, whom to give low molecular weight heparin, and whom to give LIT, and whom to give tacrolimus. It's all about the one test away.
Dr. Radha?
Yeah. So, good evening, sir. Good evening. And it is a
Yes.
very excellent lecture, sir. I am not an infertility specialist. I don't know much about these immunological factors of infertility, but you explained it in a very great way, sir. Thank you so much.
Thank you.
I have heard your lectures many a times regarding infertility in AACOG and other conferences, sir. Sir, you are an excellent teacher and an academician, sir. Thank you very much for
Thank
your
you for your kind
wonderful
words.
lecture, sir.
So
Thank
Madhu,
you.
there are a few questions in the chat box. Quickly just
Yes.
answer. Yeah.
Okay. So the first question goes, does endometrial immunoprofiling is of any help? I think in the context of RIF, they are asking if the endometrial immunoprofiling is of any help in the context of RIF and RPL.
Yes, I think so. We are still, let me tell you something. It's all about that a local decidual natural killer cell, if they shows they are deactivated with the help of only progesterone. So we are still not implanted. But if there are more deactivations will be there, then we need to activate. So I think so. This is I still not went for because I still believe that there are good laboratories needed to give a very better output. And slowly, gradually, I will build my experience. But what I learned from Natalie